As you know, this IAMICON is a wonderful program which has been pioneered or thought of or dreamt by none other than Indravadan Ambalal Modi, whom I had an interaction long time ago. And with his dream, in 2013, this whole process of starting this all across India has started and begin with 33 cities. Last year it was 49. Today it is 100 cities which is going to be held. Incidentally, today also at Calcutta and Delhi it is going to be held. And I'm sure with this kind of progress and the interest that is generated all across India, soon it will be 1,000 cities that will have this kind of program. And it is a wonderful dream that I can say, somebody has said Mahatma, but I would say Bhishma Pitama or medical man of pharmaceutical industry has thought about this brilliant idea, and that has really produced so many innovators and excellent physicians all across India. And I must really give him this honor of having this wonderful program today. As you know, I think my job has been done. It's very easy because of my teacher, Dr. Jamshed Dalal, who has been there. And probably with so many cardiologists here in this audience, the only resemblance that I have with those is that I have had my angioplasty done 5 years ago, and that is the nearest to cardiology that we have come. And my job, as I said, that these complex pathways have been really simplified and told by Dr. Dalal, so I don't have to really go into details, but I'll give you a brief video about it. Today's topic I am going to discuss is the disease burden that we have of arthritis, the pathophysiology which has been discussed so far, and the current options and limitations that we have with us, and the role of novel anti-inflammatory agent. We know that rheumatoid arthritis and osteoarthritis is a big problem now. We have almost 30 million sufferers from rheumatoid and osteoarthritis in India, though exact number is not known. This is a rough statistics, and this is going to increase day by day. And this kind of disease burden is not going to get solved easily with simple medication or simple anti-inflammatory drugs. We have certain surgeries like joint replacement surgeries, but even if we do a lack of surgery every year of knee replacement, it is not going to solve the problems. So this is rheumatoid arthritis, is a systemic disorder characterized by chronic inflammation and polyarthritis of unknown etiology. The inflammatory state also involves, besides the joints, we have skin, eyes, lungs, blood vessels, which also get affected by this. And we have a fluctuating clinical course most of the times and unpredictable prognosis. As Dr. Dalal said, it is associated with 60% increase in the risk of cardiovascular related deaths, and it has complex and multifactorial pathogenesis. The rheumatoid arthritis pathophysiology I am going to discuss, but it is basically activation of macrophages by antigen presenting cells and T cells, which releases TN alpha and IL-1 or sometimes IL-6 also, which leads to synovitis, the cartilage degradation, and also articular damage. In osteoarthritis, it's the same IL-1 and IL-6, also IL-17, which also is responsible for cartilage damage and also inflammation of the joints. The rheumatoid arthritis and osteoarthritis, the pathophysiology, as Dr. Dalal has also already told you, that this TNF alpha and IL-1 are the major inflammatory cytokines involved in RA as well as OA. Release of these inflammatory cytokines is regulated by NF-κB or nuclear factor kappa B. This is a transcription factor presentation in all the cells. It plays an essential role in inflammation and immune responses. So this acts like a major switch, which if it is on can give rise to inflammation, and we have to see that it is off all the time. Because disorders of NF-κB activation can lead to RA, OA, ankylosing spondylitis, psoriatic arthropathy, and also juvenile rheumatoid arthritis. So NFKB is the master switch we have to really control when we have to control the inflammation. This pathway has been already discussed, but what I'm going to tell you is, I'll just give you a Star Wars kind of view of the pathophysiology. Yeah, okay. So I'll give you this 3-minute video which will give you this brief outline of the pathogenesis of rheumatoid arthritis.
The pathologic hallmarks of rheumatoid arthritis include inflammation of the joints, particularly the small joints in the hands, wrists, and feet, accompanied by cartilage destruction and bone erosion. Underlying inflammation leads to many of the characteristic signs and symptoms of RA, such as pain and swelling of the joints. Inflammation results from abnormal propagation and activation of many types of immune cells, resulting in the secretion of cytokines and other mediators that sustain and amplify the inflammatory environment. As a key pro-inflammatory cytokine, TNF-alpha, along with other cytokines, activate immune cells, including macrophages, as well as other cells such as synovial fibroblasts. In a key step, activated macrophages and synovial fibroblasts release pro-inflammatory cytokines, including TNF-alpha, IL-1 and IL-6, and mediators of vascular growth, including VEGF. VEGF is essential to the process of blood vessel proliferation, or angiogenesis, which facilitates an influx of activated cells. These cells contribute to the growth of pannus and sustain the inflammatory cycle. The growing, vascularized pannus develops villous projections that result in better access to the cartilage and bone, and therefore greater opportunity for the activated cells to release damaging inflammatory mediators and enzymes. In the interface between pannus and cartilage, activated synovial fibroblasts and macrophages are a source of enzymes that degrade the cartilage matrix. These include MMPs, or matrix metalloproteinases. Thus, activated cells in pannus are key instigators of cartilage destruction. Chondrocytes are the main cellular component of cartilage and normally produce the extracellular matrix. However, in response to stimulation by TNF-alpha, IL-1, and other inflammatory mediators, chondrocytes become activated in the rheumatoid joint. Activated chondrocytes secrete more inflammatory factors and more metalloproteinases, MMPs, which aggravates inflammation and cartilage damage. The cumulative result is irreversible cartilage damage and joint space narrowing. Under normal conditions, bone remodeling involves a tightly regulated balance between bone resorption and bone formation. However, excessive TNF-alpha helps stimulate osteoclastogenesis and bone destruction. In the marrow, TNF-alpha helps stimulate monocyte differentiation into osteoclast precursors. At inflamed joints, in the presence of macrophage colony stimulating factor, TNF-alpha, and rank ligand, osteoclast precursors differentiate into mature osteoclasts, resulting in bone resorption. Thus, the direct and indirect effects of the TNF-alpha on osteoclast maturation and activation culminate in focal bone erosions and irreversible joint damage.
Yeah, so we are talking about this NFKB inhibition, and we'll find out how it is brought about. This curcumin, as has been described before, it is biologically active phytochemical compound obtained from rhizomes of Curcuma longa. It possesses diverse properties of anti-inflammatory and antioxidant, and also there have been more than 65 clinical trials with more than 1,000 patients have been actually checked into these trials. There are about 35 ongoing clinical trials which have been done on curcumin. And this is basically a NFKB inhibitor which controls the NFKB activation and the inflammation. So it acts on various sites which has again been discussed before. What is the incidence and evidence of curcumin in RA and OA? In this comparative study of curcumin with diclofenac, curcumin was used with diclofenac, and it has been shown that it has a greater improvement in disease activity score and ACR, that is American College of Rheumatology, as compared to diclofenac. 52% reduction in CRP levels with curcumin was found, and it is extremely effective and safe in patients with active rheumatoid arthritis. There is another study which has been a pilot study when 18 patients with rheumatoid arthritis were treated with curcumin for only 2 weeks, when it improved joint swelling, morning stiffness and walking time. It was very well tolerated and better GI tolerability. The curcumin is effective and well tolerated in the treatment of rheumatoid arthritis. That was the conclusion. In osteoarthritis, when it was a real life experience with curcumin monotherapy was given in 820 osteoarthritis patients attending OPD, were treated with curcumin for almost 6 months, and in the conclusion, the curcumin therapy provided significant improvement in pain, improved joints flexibility and better quality of life. 50% of the patients were able to discontinue use of NSAIDs and analgesics. So it was found that it was well tolerated, it relieves pain and reduces need for NSAIDs in the osteoarthritis. Again, another study when 367 primary osteoarthritis of the knee were given curcumin with ibuprofen. The patients who had pain score of more than 5 were randomized to receive ibuprofen or curcumin for 4 weeks. Significant decrease in WOMAC score, pain, stiffness and functional score from baseline in both the groups were found. Curcumin was found as effective as ibuprofen, and lower incidence of GI adverse effects in curcumin group. So it was concluded that curcumin is as effective as NSAIDs but has better GI tolerability. In another study, when 100 patients of osteoarthritis were treated with curcumin for 8 months, results were significant decrease in serum inflammatory biomarkers, especially IL-1, IL-6, soluble CD40, etc. There was more than 50% decrease in the WOMAC score, threefold increase in the treadmill walking performance. In patients already on NSAIDs and analgesics, co-administration of curcumin was associated with decreased need for NSAIDs, and there was a marked reduction in GI side effects. So conclusion was curcumin was effective and safe for long-term management of osteoarthritis. In another study, when 88 patients with primary osteoarthritis of the knee were randomized, and 44 patients were given diclofenac alone and other 44 were given diclofenac with curcumin. As compared to diclofenac monotherapy, combination of curcumin with diclofenac was associated with greater pain relief, better improvement in knee injury and osteoarthritis outcome score. So the conclusion was curcumin when combined with NSAIDs provides additional benefits. So in curcumin with combination therapy, when given along with celecoxib, it enhances action of celecoxib on COX-2, decreases need for celecoxib. When it was given in combination with prednisolone, additive anti-inflammatory action through inhibition of inflammatory cytokines and significant reduction in joint swelling was seen. Reduction in side effects due to steroids was also seen. Curcumin when administered with methotrexate provides synergistic anti-arthritic action, may help in reduced dose of methotrexate and reduced risk of hepatotoxicity and hematological toxicity. So curcumin was found to be safe and it was generally recognized as safe by US FDA. No noticeable adverse events were observed with doses up to 8 grams daily up to 3 months. Unlike NSAIDs, free from adverse effects on kidney, liver or cardiovascular system even after long-term use. Occasional patients may complain of mild or transient nausea or diarrhea. So unlike NSAIDs, steroids or DMARDs, curcumin was very well tolerated. So this is a novel formulation. Though when conventional curcumin or haldi which was given, it is poorly water soluble, polyphenolic compound, poorly absorbed from GI tract, undetectable in plasma, doesn't reach systemic organs or tissues. So efficacy is really questionable. The Clinical trials carried out with conventional curcumin was they had to use very high doses up to 12 grams per day. Few studies have not shown positive results and poor GI tolerability. So there was a need for bioavailable, effective and well-tolerated curcumin formulation. So this is what is the technology, the SMARTS technology, which is self-micro-emulsifying drug delivery system, where this is much more bioavailable and it has been developed. So this technology provides nano-sized hydrophilic droplets of curcumin, improved absorption is seen and better tissue penetration, and this is what the whole advantage of this system. And bio-enhanced curcumin, the human pharmacokinetic study have shown that higher bioavailability is there from this graph. So this bio-enhanced curcumin, the dosage is about 100 to 200 milligram per day as discussed before, but exact dose of this drug may vary from patient to patient depending upon the disease activity and severity, disease of inflammation and patient response. So if required, this dose can be increased up to 4 milligram per day. So this curcumin, which is bioenhanced, it inhibits the master switch of inflammation, that is NFKB, decreases the release of inflammatory prostaglandins and cytokines, especially this TNF alpha, IL-1, IL-6, etc. Monotherapy has been found to be extremely effective and safe in treatment of both rheumatoid arthritis as well as osteoarthritis. Efficacy is at par with NSAIDs, but with better GI tolerability, can be used along with NSAIDs or steroids, provides additive or synergistic action which helps in dose reduction of this. Can be used along with methotrexate, helps in reducing the risk of hepatotoxicity. And unlike biologics, which are available now, which are used very extensively by rheumatologists, this is an oral drug, so it is extremely useful and well tolerated and safe. Suitable option for monotherapy as well as combination therapy is seen. So bioenhanced curcumin has a place in therapy. Attractive option for management of both rheumatoid arthritis and osteoarthritis, either as a monotherapy or in combination along with NSAIDs. Particularly useful option in following groups of patients: intolerant to NSAIDs, steroids or DMARDs, compromised renal functions, hepatic dysfunctions, CV disorders, hypertension or chronic heart failures. Effective, safe, well-tolerated treatment option that we have, and soon it will be available in the market, I think within 6 months. So I think this has tremendous future, especially in management of arthritis. Thank you very much.